training, he was appointed as a consultant at Westminster Children's Hospital, where he ran bone marrow transplant service. In 1994, he moved to Great Ormond Street, where he established a lysosomal storage services. He has been internationally known for his work in the field of the lysosomal storage disorders, and he has run several clinical trials. He chaired the European Working Group Committee for Type 3 Gaucher disease, developing guidelines for its management. He has over 100 peer-reviewed papers and 3 textbook chapters to his credit. And he's a recipient of Alan Gordon Memorial Award of UK Gaucher Association and delivered the ISIEM Oration Lecture in 2015. For 15 years, Dr. Velodi has been working with colleagues, support groups, family members across India, conducting clinics, CMEs. And also actually is a great source of help when if you have any questions, you can actually reach out to him regarding diagnosis management or anything. So over to you, sir.
Thank you, Deepanjana, and thank you for organizing this. I'm very pleased to be here at this premier institution in Kolkata. So I've got 2 talks today. The first is on recent advances in LSDs, and the second is the clinical management of mucopolysaccharidosis. I've got a third talk, if there's time and if people are interested, on interesting and challenging case presentations, but we'll see how time goes. Now, as far as recent advances are concerned, I've had to be fairly selective. This is, yeah, where? This is a very rapidly expanding field, so I've had to be selective in what I've chosen. So I've chosen some basic science areas, some clinical areas, which I hope are of interest to most people here. Sorry, this is not working. Ah, okay. So the lysosome was discovered by Christian de Dieu, a Belgian biochemist, in 1955. And I'm sorry that this is rather fuzzy, but he was not the only recipient of the Nobel Prize in 1974. He shared it with Georges Ballard and Albert Claude for their discoveries on the cell. And Albert
But I'm in 30 to 40 minutes and then the discussions. So if you can
both talks. No, I'll just do one talk.
Because the residents are working.
Yeah. Okay, so I'll just do one talk. That's okay. So Albert Claude, this was his Nobel Prize lecture. We have entered the cell, the mansion of our birth, and started the inventory of our acquired wealth. So if you want to understand lysosomal storage disorders, you've got to understand cell biology. Do not make the mistake of depending on molecular genetics alone. So very quickly, lysosomes are intracellular organelles, which are responsible for breakdown of waste product. Sorry, can I just say, would you prefer this or the MPS lecture? It sounds as though we don't have time for both, so you can choose. Okay, so we switch to the MPS. Okay.
The only problem is the peak hour of the work.
Yeah, no, absolutely. Sure, sure. Okay, so this is clinical management of mucopolysaccharidosis, and there have been a lot of recent advances, but I'm going to just start with the basic clinical management, which I feel should be available in every hospital looking after these children. Now, so the list has been expanding, and there are now, it goes up to MPS-10. There are 2 gaps in between. Does anyone know why? So why is there no MPS-5 and why is there no MPS-8? Okay, so MPS-5 was originally described separately as Shay's disease, but then it was shown that it had the same enzyme deficiency, so it was moved to MPS-I. But the convention states that that MPS has to remain blank. Similarly, with MPS-8, there was an MPS-8 described, but then it was discovered that it was not actually an MPS at all. So that's also blank. So the most recent one is MPS-10, aryl sulfatase K deficiency, probably the rarest. What are mucopolysaccharides? They are long, unbranched polysaccharides consisting of repeat disaccharide units, and there are 4 groups: heparan sulfate, chondroitin dermatan sulfate, keratan sulfate, and most recently recognized hyaluronic acid. So it's a bit small, it's not come out very well, but you can see on the top, you have heparan sulfate. There are 3 pathways: heparan sulfate degradation, keratan, and dermatan sulfate degradation. And they are broken down in steps sequentially by a series of lysosomal enzymes. And depending on the step and the deficiency of which enzyme is deficient, so that disease becomes apparent. And this is the list of the disorder with the deficient enzyme and the stored glycosaminoglycans. This information is readily available everywhere. They're all autosomal recessive except for MPS-II, which is X-linked recessive. So MPS-I shows a clinical spectrum from severe Hurler's disease on the left to mild Shay's disease on the right, with intermediate Hurler-Shay disease in the middle. And these are pictures of the same child taken from birth, progressive pictures of the same child. And you can see that at birth or shortly thereafter, the diagnosis is not that obvious. Later on it is, but by then it's too late. Sometimes the appearance of the hands and x-rays give you a clue. You can see these broad spatulate hands with proximal pointing of the metacarpals. Very, very classic. Significant, this is a gibbous. This is the clinical hallmark of MPS-I-H. You do not see it in the milder versions, milder forms. So you don't see it in Shay's disease, and you don't see it in Hurler-Shay disease. And by and large, they all look very similar. So if you've seen a lot of them, you can make the diagnosis fairly easily. They do exhibit dermal melanocytosis, and this is very common in India. This is a very important clinical clue. This is Hurler-Shay disease. It's not that mild, actually. These children have very severe problems, but their intellect is relatively well preserved, which makes things even worse because they're aware of their problems. They survive with all these terrible complications. These are 2 of my patients in London, a brother and a sister who have Shay's disease. And they were both on enzyme replacement therapy. The sister on the left was actually younger, but far more severe. She developed double aortic and mitral valve disease, for which she had to have surgery. And during the operation, she went into, so what happens when you anesthetize an MPS patient, you have to be very careful because anesthesia is very, very tricky. So we did tell the anesthetist, and she was seen by several anesthetists, but on the table, she went to glottic spasm, okay? Then they tried to, but they couldn't intubate her. Then they did an emergency tracheostomy. And what do you think happened? What happens when glottic spasm is acutely relieved? So when you go into glottic spasm, your intrathoracic pressure rises. What happens when intrathoracic pressure, raised intrathoracic pressure, is suddenly released? Pulmonary edema, exactly. So she went into pulmonary edema on the table. And so she had to go to the intensive care unit to be ventilated. And during the tracheostomy, which is not done well, she had recurrent laryngeal nerve damage. So she ended up with a nasogastric tube, a tracheostomy, and being on a ventilator for months. Fortunately, she came through all that very, very quickly. Very well. These I've already shown you, very, very classic X-rays. So let's move on to MPS-II. These are 3 boys with MPS-II. As you know, it's X-linked recessive, and you can see the similarity in their features. And you can see the difference. Now, which one do you think is MPS-I and which one do you think is MPS-II? Right. So the one on the left is MPS-I. He has corneal clouding. On the right, no corneal clouding, MPS-II. But here's, so this is an Indian child. He presented to the clinic in, he was picked up because his brother presented to the clinic in Chennai. He was picked up in the railway station. So, you know, in the large railway stations, you have these groups of children who run away from home. And they're sort of adopted by the railway staff. And this child was just running around. And they brought him to the clinic. And he was in a, he would not let anyone touch him. He sat in a feral position and he was covered in dust and couldn't get a blood sample. He died a few months later in a cholera epidemic. But by then, the social workers had traced the family back to the village where they found his brother. And you can see the brother shares the clinical features, the facial features of MPS-II with these 3 boys on the left. So it doesn't matter what the ethnic origin is, the facial features are remarkably similar. I don't know whether that's come out very well. They have these papules over the scapula. It's a clinical hallmark of Hunter's disease. You can actually almost make a diagnosis. No other MPS presents with this. So MPS-II, different facial appearance. The main clinical problem is diagnosing neurological involvement. And this may be very difficult to diagnose in the first 5 years. So here you have 2 boys with MPS-II. Clearly, the one on the left is well preserved intellectually, and the one on the right is not. They are the same age. The key is to make a diagnosis of incipient or potential neurological involvement at an early age. Why? Why? Well, managed better, yes, but you would not treat the one on the right with enzyme replacement therapy because it's not going to cross the blood-brain barrier, right? So there's no point starting it, even at the age of 2, when you know it's not going to work. You should have tools for early diagnosis of neurological disease. The one on the left is very amenable to ERT. It's a fundamental difference in MPS-II, and it's not as easy as an MPS-I, okay? This was published many, many years ago. General differences between the so-called mild and severe forms. You can see different age of onset, different age of death, a lot more cardiac involvement in the mild form. And the cause of death in the mild form is predominantly cardiac. So how do you pick up early neurological involvement in MPS-II? So this was published from Duke University by Marie Escala and her colleagues, I think, well, she was still at Duke, many years ago. And they identified certain markers. So they identified 6: increased activity, behavior difficulties, seizure-like behavior, sleeping problems, chewing behavior, bladder training, and bowel training. Sorry, 7. And you can see the marked difference between patients who were, these were tests that could be applied even to very young children, okay? Now, having said that, it can be very, very difficult. So we had a child who was actually born to a hunter mother, okay? So the mother had a severe mutation, but had very mild phenotype. Why? Sorry? Yes, but why did she have a mild phenotype with a very severe genotype? Right. Skewed X-linked inactivation. But it was predicted that the child, if a boy, would have severe hunters. She refused prenatal, okay? So we had to allow the pregnancy to continue to term. We stopped enzyme replacement therapy during pregnancy, by the way, because it was the first pregnancy in the world actually described for hunters. And he was born and looked perfectly normal. So the question is how to pick up early neurological involvement. And who do you think was the first person to pick it up? First professional. Not a pediatrician, by the way. No, it was the play specialist. So what we decided was that we would have a schedule of play specialist assessment, right? Because that's the only way in very young children that you can pick up early aberrant signs, okay? And within 3 months, this play specialist came to us and said, this child is not playing properly. That was the only sign. So we went ahead and did a bone marrow transplant. That was very experimental, by the way. It's not published. I wish it were. Mild MPS-II is by no means mild. This is an older patient of mine in London. And you can see he's pretty much bedridden. He's got claw hands. He's got, what you can't see is the tracheostomy, severe heart disease. He couldn't handle coins. So when he went to the shop, he used to flip coins like this to get them out of his purse. He had a very severe voice impairment. They get very severe voice impairment. He died a few months after this was taken of cardiac disease. These are 2 brothers I saw in clinic in Chennai. And you can see immediately they are intellectually preserved, right? But they both have raised intracranial pressure. The one on the right, the older boy, has lost his vision. Why? Because of raised intracranial pressure. Exactly. But the anesthetist wouldn't go anywhere near him. You can see, immediately you can see he's got raised airway, he's got upper airway obstruction. And he couldn't get a shunt because of this refusal of the anesthetist. This is all over India, by the way, they went to different centers. So he died, sadly, shortly after this photograph was taken, and so did his brother a few months later. This was before enzyme replacement therapy became available, but you can see the very traumatic lives these children, not children, young adults had to lead. So most cases in MPS in females are due to skewed X-linked inactivation. If you don't know what that means, you need to read it up. Sometimes you can get balanced reciprocal translocation disrupting the IDS gene, and sometimes you can get partial deletion of the long arm of the X chromosome. There are various causes. So this is the mother of the boy I was telling you about. She had a successful marriage, pregnancy, and enzyme replacement therapy. So most MPS II heterozygotes are asymptomatic, and it's not very clear why. There's a huge contrast with Fabry disease. This was actually, I was going to show this in my other slide. Can anyone think why? So both X-linked recessive disorders, right? We know that Fabry heterozygotes can, a lot of them are symptomatic. They have clinical signs and symptoms. But not the case in MPS II. Why? Think about that. If we get time, I'll show you the slides showing you the answer. So they get dysostosis multiplex as well, but a different type from MPS I. And you need really experienced radiologists to look at these things and tell you which one it is. MPS III was described in 1963 by Sanfilippo, and there are 4 different genes. It's mostly neurological. There are 3 stages. The first stage is where they go undiagnosed. And you can read all this up. There's nothing very new about all this. So here we have 2 children. On the left is a child who was perfectly normal to all outward appearances, but was diagnosed because her older brother had just been diagnosed. She was one of twins, identical twins, so both were affected. So this family ended up with all 4 children being affected. And this is the tragedy of MPS III, that the early signs go undetected and undiagnosed. On the right, you have a boy with very typical features, but by then it's far too late. There can be a sort of a phenotypic spectrum, as you can see. The mortality in MPS III has reduced over the years. So just look at the graphs on the right, okay? So x-axis is the year and y-axis is age at death. So you can see that from the 70s to this century, the age at death has been gradually increasing for both MPS-A and MPS IIIA and IIIB. That means that it's become more and more amenable to some sort of intervention. Okay, there's hope for that. The cause of death, MPS IIIA on the left, MPS IIIB on the right. This is from 2017 from Christine Lavery and Chris Hendricks, and you can see that the majority of deaths for MPS IIIA are with pneumonia, whereas there's not so much with MPS IIIB. But this is very, very general, and there's no hard and fast rule about this. Okay. So cause of death, virtually no neurological deaths in MPS III. Very important to remember that. Very significant cardiorespiratory involvement. Cardiac involvement should be actively looked for in MPS III. I've had several patients who've got very significant cardiac involvement with myocardial impairment, and have had to have treatment actually for that. Coming on to Morquio disease, this is an early presentation with dysostosis. It's very visual, therefore it tends to be picked up early, and it's rarely missed. They're intellectually preserved. So on the left, you have a classic adult Morquio in a wheelchair, and on the right, a mild Morquio in the same clinic room at my clinic in London. You can see the difference in size. The lady on the right is perfectly mobile. How was she diagnosed? She was presented with, at the age of 6, with neck pain. The pediatrician took an X-ray. The radiologist diagnosed it as spondyloepiphyseal dysplasia. So that's it. Then her sister presented. at the age of 6 with neck pain. And this time, the x-rays were looked at by a radiologist who knew what they were looking at. And she said, this was Christine Hall at Great Ormond Street, very well-known radiologist. And she immediately said, this is Morquio's disease. So we went back to the sibling, to this lady, and of course, she had Morquio disease. We assessed her, she had cervical instability. She had to have an urgent emergency cervical fusion. By this time, actually, she was happily married with 3 children. So you can imagine the urgency. They come from a village in Kashmir, where there's a very high incidence of these children, patients in the same village, probably endogamy. This is another adult patient of mine, a gentleman from Northern Ireland. So the Northern Ireland group of Morquios have a very unique genotype, and they present very late with this sort of picture. Now, Glenn was working as a government officer, and he was fairly well preserved. He had problems with the large joints. He had no cervical instability, okay? But he needed crutches and things. The other problem he had was driving at night. Why? Yes. What would that do? Why at night? Not pupil dilate, but it's like looking through, a fog. Exactly, it's like looking through a foggy sort of. Exactly. So he couldn't drive at night. That was his only limitation. Okay? He had to have joint hip replacement surgery, not neck surgery. And he was considering shoulder surgery. So these patients have large joint involvement. MPS-I was described in 1963, and this can be, they have dysostosis, but normal intelligence. These are several patients with MPS-I, and you can see the very similar clinical features in all of them. This patient was referred to me as Morquio. You think she's got Morquio? Well, the answer is no. I mean, she's got no features at all of Morquio. Okay. So they get radiological problems. Let's move on to MPS-VII. It may present with hydrops, but hydrops does not predict severity. So here's a child who presented with hydrops, but survived till adult life. And actually, I think he was the first to start enzyme replacement therapy for this condition. Natowitz syndrome, relatively mild. I'm going to go very quickly through this because these are so rare. You're unlikely to see them. Now, when we come to screening, a lot of us do glycosaminoglycans, but that's going out of vogue now, okay? People are now turning to glycan-based biomarkers, in other words, metabolomics. And that's based on the non-reducing end of these sugars. And I won't go into detail, this has all been written up, but very, very precise diagnosis can be made. And this was published in 2019 by Jenny Saville and her group. And
sorry, just interrupt you. When the biomarkers, can we have the categories? Sometimes of the MPS?
yes.
Can we have the type of MPS?
Yes.
Yeah.
We can have, sometimes not the specific one, like one particular might have DS and like HS, you know that it's this, but maybe not that specific. It narrows it down now.
And that is why it's going out of vogue. So this is where It's got to. So this was a paper where they looked at liquid MS, tandem MS. A single urine sample provides a precise diagnosis. Why? Because each MPS has a signature oligosaccharide. 93 individuals were correctly diagnosed, correctly diagnosed, out of a total of 723, 100% sensitivity and 100% specificity. That is far better than you would expect with GAGs. And not only that, it correlates extremely well with urinary glycans, a very good biomarker. It comes down with treatment. That is the way things are going. So what are the clinical problems? So the behavior in MPS-III, there are 4 types of behavior that we see: attention deficit disorder, oppositional defiant disorder, autistic spectrum disorder, and depression. And you get combinations of these in different patients. They have problems with sleep in that the circadian rhythm is altered. If you look at their melatonin levels, they're highest in the morning. Should they be highest in the morning? No, right. They have swallowing problems, oropharyngeal dysfunction. They take a long time to chew and eventually choking, aspiration, and they stop swallowing altogether. They do get, MPS patients do get raised intracranial pressure and usually presents with visual impairment. Remember that, not with a typical sun setting sign and vomiting, visual impairment, okay? So if a patient with the MPS says he can't see well, immediately do a scan. So there are 2 main causes, hydrocephalus and craniosynostosis. And here you have both, and they're very different. When would you suspect craniosynostosis? Hydrocephalus is easy. When would you suspect craniosynostosis? Yes, so head circumference. So yes, so basically with these children, you have to monitor their head circumference. A lot of people make the mistake of just taking the height and weight, right? If you don't take head circumference, you will miss this because you will see a tailing off of the head circumference, which is a red flag for craniosynostosis. So this is the boy prior to his surgery for craniosynostosis. That's just a 3D CT scan that the neurosurgeons like to do. Sorry, and you can see that the sagittal suture is completely fused. And you can see this very small head with large ventricles, but what else do you see? You can see periventricular edema. You see around the ventricle? That is a sign of raised intracranial pressure. And this young engineer from Chennai, again, presented a very sad case, again, with raised intracranial pressure. So what are the eye problems? Corneal clouding, retinopathy, and glaucoma, which you must remember is open angle. It is seen in MPS 1, 6, and 7. It may be seen in MPS 4A, but it's more sort of corneal infiltration. They don't really get clouding. The other thing you do get in MPS 4A is exposure keratitis, secondary to shallow orbits and proptosis. But it may be secondary to glaucoma, the corneal clouding. So here you have different pictures of corneal clouding. You can see that there are different degrees, and you just have to be alert. They get GAG accumulation in the retinal pigment. The rods are affected earlier, so night vision is affected early, and it's very frequent in MPS 3, and that's disastrous. So can you imagine an MPS 3 patient who's losing his night vision and stumbling around at night who can't see anything? Very traumatic for the family. So these are some pictures of retinopathy and MPS. We have now started doing OCT, which stands for optical coherence tomography, right? And you can see, look at the width, the thickness of the different layers of the retina, and there are very classical, typical features that you see in these children. The glaucoma is usually open angle, although angle closure glaucoma can also be seen. The trabecular mesh becomes distorted. They get spinal cord compression, and there are two causes: bony due to cervical instability, and soft tissue secondary to ligamentous thickening. Cervical instability in MPS-IVA is seen from a very young age. Clinical signs usually appear by the age of 6 or 7, but you do not wait for that, because that is a disaster. If you operate on a Morchio patient after clinical signs of cervical cord compression have appeared, the results are terrible. These are just some X-rays that you have to do. You must do X-rays of the cervical spine in flexion and extension to look at the movement, the atlantoaxial distance, and how that moves with flexion and extension. And you're allowed a certain movement, otherwise your neck would be fixed, or obviously, but usually about 2 to 3 millimeters. Anything more than that, suspicious. What's interesting is that in Down syndrome, you can get movement of up to 13 millimeters without these sort of problems. So there are additional problems with MPS that compromise the cord at a much smaller atlantoaxial distance. You do a CT scan. What strikes you about the CT scan on the right? So that's normal. So, sorry? There's no odontoid peg. Do you see the odontoid peg? Can you see it on that? No, it's gone. So they get hypoplasia of the odontoid peg, and that's why the atlas and the axis move around on each other like that, because it's the odontoid peg that fixes the atlantoaxial joint. So there you have cervical cord compression. Surgery is life-saving, but must be performed early. So they must have regular monitoring. As soon as the diagnosis is made, immediately baseline cervical spine X-rays and an MRI, and then follow up X-rays every 6 months, MRI once a year. They get ligamentous thickening, you can see that. Respiratory problems, they have restrictive airways disease, obstructive airways disease, both upper and lower airway. And anesthesia in these children is an art. It's not just a skill. You can see you must always carry out awake. You can see he's putting him to sleep without putting the tube down. There's many anesthetic risk factors in MPS. That's the glottis. Can you imagine trying to get a tube into that? And you can see how it becomes deformed. That's a trachea of an MPS-4 patient, I think, severely deformed. And they get deformed below the level of the glottis. And that's where the problems really arise, because even if you do a tracheostomy, you can't bypass this below. They get different types of cardiac involvement. This was the classic. If you've read the old pathology textbooks, you'll see this description of endocardial fibroelastosis. Many of those children actually had Hurlers. This is endocardial fibroelastosis. So this is the same child. What's the difference between the two photographs? Anyone? Yes, he's got central cyanosis. So what? Sorry? No, he became cyanosed. So, yeah, therefore, what would you look for? It's not congenital cyanotic heart disease. So what is it? Pulmonary arterial hypertension with right reversal of the shunt. Okay. Yes, right, with right to left shunting. As soon as he walked in, now it's very easy when they've got two photographs side by side, but when he just walks into the clinic on the right like that, not that easy. Carpal tunnel syndrome is usually asymptomatic and can cause an acute painful hand. Remember that. So that's the median nerve at the wrist at surgery. Now, do you have time for this or should we stop? There's quite a lot. Okay, so let's start with behavioral problems. The psychiatric phenotype I've told you about. So you have to determine which neurotransmitter. It's not just a question of giving them Ritalin. Okay, you have to determine which neurotransmitter system is affected. Dopaminergic, GABA, ACH, serotonin. Now in ADHD, you get depression of dopamine and norepinephrine. In autism, glutamate is affected. How do you manage it? CBT usually doesn't work, so forget it. The types of medication required are aripiprazole, risperidone, methylphenidate, mood stabilizers in different combinations. Remember that sodium valproate, although it's an anti-epileptic, it's also a mood stabilizer. So is carbamazepine, okay, in different doses. So if a child is on sodium valproate for his epilepsy, you may tweak the dose to stabilize his mood. Risperidone is a dopamine antagonist. Aripiprazole is a dopamine agonist. Methylphenidate, both. So different ways of handling this. Sleep.
Especially cautious of any side effects that may occur.
Very much. So we work very closely with Dr. Santosh. He's a psychiatrist. He's actually from Kerala, but he's a psychiatrist now in London. And he found that you never, ever start, you don't just open MIMS and prescribe, they immediately go into side effects. You have to start with a tiny dose and gradually increase based on the half-life of that drug. And every few weeks, you have, so San Filippo, the good thing is you can have telephone or video calls. They don't have to come to clinic. You conduct a telephone before the next dose increase, and then gradually increase. And he found that actually the doses he required were far lower than has been prescribed in the textbook. Right. So that's, for me, that was a lesson learned. Sleep disorder, as I told you, they get disturbances of circadian rhythm. Melatonin is the drug of choice. Sedatives are much less effective. You can pour sedatives into these patients and nothing happens. It's amazing how much chloral hydrate they can just absorb. And very, very high doses needed. But first, make sure there's no obstruction. You don't want to send a child to sleep who's got airway obstruction. This has happened once in my experience. He actually arrested at night because he couldn't actually wake up. Swallowing difficulty. In the early stages, you change the consistency of food. Later, you start nasogastric tube with gastrostomy and fundoplication. You must control saliva production, either with hyoscine patches or glycopyrrolate, because once you put the tube down, they don't need their saliva, right? So you can dry up the saliva. Why do you need to dry up the saliva? Because otherwise they pool and aspirate on the saliva. So you dry it up. Glycopyrrolate is much better, but you have to give it quite frequently during the day. That's the problem. Hyoscine patches are easier, but it's a little bit more guesswork. you must consider prophylactic gastrostomy in these patients at an early stage, because so many children I've seen, parents and clinicians have made the mistake of delaying it too long. So what happens is they get recurrent infections, recurrent aspirations, and they become quite emaciated, okay? Their lung function deteriorates, and they actually become very poor anesthetic risks. So doing a fundoplication at that stage is, but trying to persuade parents to do a gastrostomy at an early stage is very, very difficult, I can tell you. So we do a video fluoroscopy study. This is done by the speech and language therapy. It's very important that all centers have dysphagia speech and language therapists. It's not enough just to have a speech and language therapist. You've got to have a speech and language therapist who's trained and skilled in dysphagia assessment. And they do these assessments. So you want me to stop? I mean, I can go on for or not. I can just go on if you want, and whoever wants to stay can stay. Sorry? Yes, no, I'd like to complete it, but if people have to go, then. So this is hydrocephalus. On the left is the scan pre-shunt, on the right post-shunt, and what's happened? What is the complication that has happened on the right? Sorry?
Anybody who has to leave can leave, but others can.
Yeah. So what is that complication? So the shunt has gone in. You can see that. Ventricles are smaller, but what has now appeared? He's got a subdural effusion. Can you see it? Yeah. And if you do it too quickly, it can actually be a subdural hematoma. You've got to be very, very careful about the type of shunt you put in. So first, typically you measure the pressure, decide what type of shunt, low pressure, high pressure, whatever, and then do it. Don't just stick a needle in. Surgery for cervical instability, typically combined fusion and decompression. The fusion may be occipito-cervical or cervical-cervical, and is usually performed with a rib strut graft. Why? Because the iliac crest is usually got too much cartilage. What's wrong with that? What's the problem if there's too much cartilage? Well, if it's got too much cartilage, it's not going to fuse with, I mean, it's just cartilage. It's not going to do anything, right? So you've got to have bone, usually taken from the rib. Technically, it's very difficult in very young children in whom instrumented fusion rather than bony fusion may be necessary. And prior to surgery, you've got to put this on. Have any of you seen this? It's a halo. So it's fixed. It's actually screwed into the shoulders. And here there are screws going into the scalp so that the neck cannot move. Why does it need to be done before surgery? Before surgery. Okay, well, I'll tell you, if you don't, you're in real trouble. I was there, I remember one of my very early patients about 30 years ago. We had her on the table and no halo in those days. They didn't even heard of it. And the anesthetist just turned her over and she went into spastic quadriparesis. Immediately on the table, and she never recovered. This is to prevent that. So here you have two identical twins with MOCHIO, okay? The one on the left had her surgery after she developed symptoms. The one on the right had her surgery before she developed symptoms. Okay, just because they're identical, they don't develop symptoms at the same age. The one on the left, I've got another picture which I couldn't find of them coming into clinic with with Lorraine, who's on the left, in a wheelchair, and Samantha walking by her side. That's the difference. Lorraine died a lot earlier. Corneal grafting. There are two types of keratoplasty, penetrating and deep anterior lamella. You must preserve the Descemet's membrane, okay? That's preferred, but it's clinically quite difficult. You've got to give post-operative steroids because it's a graft, okay? So you can see this is Louise, and she had a bone marrow transplant, actually. You can see she had a corneal graft on the right. So this is lung function testing. So obstructive sleep apnea may not always be associated with apnea, okay? So don't ask the parents about apnea. You can have daytime sleepiness and snoring. In fact, daytime sleepiness is a very important clue to obstructive sleep apnea at night. And CPAP may be necessary at quite an early stage. This is for virtually all forms of MPS, okay? A child having sleep studies. And he's hooked up to various things measuring heart rate, oxygen, carbon dioxide, etc. Plus, there's an infrared video camera recording his movements. This is a child with Hurlers on CPAP, remarkably tolerant, actually. Anesthesia, I've told you, it's very complex because it has a complicated upper airway, very poor view of the glottis, and may need a flexible scope rather than a rigid scope. So that's Rob Walker in Manchester anesthetizing this child. So what are the hospital specialties required? It's a multi-specialty approach. Okay. So we'll go through this one quite quickly. Actually, so the specific treatments are transplant and all this, you know, okay. So I think these things you know, okay, HSCT and so on. So I can stop there? Okay, thank you. Well, I can show you. So there's an adequate response in these parameters, variable response in the CNS. Now, this data was published by Johan Kutzberg from Duke in 2008, cognitive function following BMT for MPS-I. And you can see that the earlier the transplant is done, the better. They catch up, actually. So the red line shows you the unaffected patients. And the continuous line just below that is unaffected children, then the patients below that, yeah. Well, that's a good question. Conventionally, it's not given. If you're fully engrafted, they don't give. So you can see the very variable outcomes. These are 3 children. And you can immediately see that they had quite different. This one on the left, this was 30 years ago. This was before any genotyping for MPS-I became available, and we were suspicious that he was mild. So we sent his fibroblasts to John Hopwood in Adelaide, and he showed us, we published this, that he would actually have had very mild disease. So nowadays, he would not have been transplanted. So the bone and cartilage, eyes and heart show an inadequate response. Sorry, how? Well, really before the age of 12 months. Ideally, but at least 18 months. You can see the
Because we get patients around 8 months, 9 months, like when they are detected. So,
Yeah. They get problems post-transplant. Have you had any transplant patients here? Yeah. So you have to follow them out. You don't just, you know this, but they get they may need corneal grafting. They get post-retinal dysfunction with retinopathy.
he actually transplanted a schematic child. Like he got the transplant from like elsewhere. He's following up with us. This child actually got transplanted around 8 months. The child was doing well, gained all the developmental milestones. But right now, it seems that the neurological things are setting in for the child. I think that's still a
Full engraftment. So this is the graph I showed you. This is the head circumference of a typical head circumference following transplant. And you can see the arrow which shows BMT, the head circumference was going rapidly up. BMT arrested it. It doesn't normalize it. Okay, so that's what you see. But when you see something like this, that is very different. So here's a child who started off at the 50th centile, sort of tailing off. And you should suspect what? We discussed it earlier. Craniosynostosis. Yeah. That was his. Doing stop? Yeah, okay.
I would like to thank Dr. Velodi for giving his time to ICH. And on behalf of all my senior colleagues over here, I really appreciate